Well, I remember while working in ICU, we receive many calls from CVTs, we receive calls from orthopedic surgeons about the possible thrombocytopenia which their patients have. I remember calls from cardiac setup and saying that this patient is developing thrombocytopenia. Probably the reason is sepsis intervening into this post-bypass patients. These patients who used to be on heparin post-bypass, because they have IVP inside from the right femoral arteries, and they develop one day, platelets start going down on the day 6, day 7 of bypass surgery. They have been successfully weaned off from mechanical ventilator. However, because of thrombocytopenia, the concern is the cause for thrombocytopenia. When they detect a huge thrombosis in one leg, in arterial thrombosis followed by leg ischemia, thrombectomy was done, heparin was reinitiated, and the platelets they started dropping from 300,000 to 200,000, from 200,000 to 100,000, and at that time the condition called heparin-induced thrombocytopenia was suspected. Already 10 to 12 days were lost in that. So coming to heparin-induced thrombocytopenia, it's a life-threatening disorder that follows exposure of unfractionated heparin or less commonly low molecular weight heparin. There are two types basically of heparin-induced thrombocytopenia. This is a newer terminology where initially it was type 1 HIT, now it is non-immune heparin-induced thrombocytopenia, which is around 10 to 30% in occurrence. The time for initiation of heparin therapy, it occurs within 5 days of heparin initiation, milder form, and the HIT antibodies are absent in this particular category. Whereas in immune heparin-induced thrombocytopenia, although it is less frequent than non-immune variety, but it typically starts after 5 days of initiation of heparin therapy. The reduction in platelet count is moderate to severe, and the risk of thrombosis is also pretty high. A quick view at this pathophysiology. The pathophysiology is a platelet factor 4 antigens which gets attached to heparin, and there is an antigen-antibody complex which forms there. And this immune complex in turn gives us the exact mechanism why there is a thrombocytopenia and why giving platelets in these patients further worsens the clinical situation. This is the platelets which are activated by the antigen-antibody complex. They are removed by spleen, leading to thrombocytopenia. Because of platelet activation, there is a release of macroparticles over here, and that subsequently leads to exaggerated thrombosis. This is one nice study or nice registry. It's called as CATCH registry, which analyzed complications after thrombocytopenia caused by heparin. This was done. The data was collected from 48 United States hospitals. This was typically done after the guidelines from the Chest Society were released in year 2008. This was data which was collected, and the data was analyzed about the patients who were treated with heparin, LMWH or UFH for 4 days or longer. This was basically done to determine the incidence of HIT, predictors of heparin-induced thrombocytopenia, to understand the significance and manage the thrombocytopenia which has occurred during heparin therapy. The observations were quite peculiar. There were around 2,400 patients which were registered in this with thrombocytopenia. The incidence of thrombocytopenia was almost 36% in this category, of which the patients who received unfractionated heparin were more as compared to those who received low molecular weight heparin. That is 52% versus 40. And the mean duration of heparin therapy was around 7 to 8 days. This is the category of patients who had thrombocytopenia. In that also, the patients who were on unfractionated heparin had a higher incidence of thrombocytopenia. What was concluded from this was, although this heparin-induced thrombocytopenia was suspected in this patient, but there was a significant delay in suspecting it because of diagnostic testing, because of call to a hematologist, because of there was of course delay in heparin cessation also once it was suspected, and the initiation of an alternative anticoagulant was also delayed in these patients. And this has typically happened after, even though the CHAIRS guidelines were released in 2008. So, they concluded with the observation that there is a serious gap between published guidelines and clinical practice in the United States. This reminds us the debate between John Louis, who has about the guidelines on surviving sepsis campaign. Well, the clinical signs and symptoms were quite typical signs and symptoms of deep vein thrombosis, arterial ischemia, limb ischemia, gangrene, etc. But there were few atypical symptoms like heparin-induced skin necrosis was found at the place where the heparin was delivered, especially bolus doses. Venous gangrene of limb was also seen. There was anaphylactic reactions to few injections of heparin, bolus heparin. And sometimes it may affect vascular bed, especially at sites of vascular injury. So that tells us why this is probably more common in surgical patients. And adrenal vein thrombosis and cerebral vein thrombosis, although the incidence was there, but it was rare as compared to other incidences. Clinical signs and symptoms, these are the extreme signs and symptoms which one can get, a cutaneous necrosis or skin necrosis. This is little bit advanced stage of obstruction, occlusion, and this is a typical gangrene because of arterial thrombus. I must mention the Professor Wagentin's contribution to research in heparin-induced thrombocytopenia. He was instrumental in forming these guidelines on treatment and prevention of HIT given by American College of Chest Physicians. Incidence reported of venous thrombosis and pulmonary embolism plus minus pulmonary embolism was around 50%. And arterial thrombosis was seen in 15 to 25%, of which, depending on the decreasing occurrence, limb artery thrombosis was more common. Thrombotic stroke was lesser common than that, and MI wasn't seen in many patients. This is another interesting table showing the incidence of HIT according to population at risk. Of course, the patients who were receiving low molecular weight heparin were of an intermediate risk, and the categories included were orthopedic surgeon, medical patients, post-operative patients, and the patients who required dialysis. More common and the patients who were falling into high-risk category were those who received heparin, somewhere around 0 to 5 to 100 days exposure. These were from the orthopedic surgery category. Intermediate category patients were from the cardiac surgery and the children undergoing cardiac surgery, and other intermediate category patients who were from medical and surgical ICUs. The frequency of clinical sequelae once heparin-induced thrombocytopenia occurs. What is the sequelae of events? The new thrombosis may occur in 30 to 50% of patients. Around 20% of the patients have to go for an amputation because of arterial thrombosis, and the mortality is also pretty high, amounting to 30%. Having understood that incidence, occurrence, definition, classification, we must now move ahead with the steps in the diagnosis of heparin-induced thrombocytopenia. So first and foremost is history of heparin administration for more than 5 days. That is the benchmark of your diagnosis of heparin-induced thrombocytopenia. Second is, once you know this patient has received heparin, exclusion of other causes of thrombocytopenia. Then demonstration of HIT antibodies by functional and other immune assays, and having stopped heparin, the recovery of low platelet count, that is one of the other important factors which we must remember in mind. Diagnosis is not easy. However, if you have a high index of clinical suspicion, it probably is easy and it might clinch the diagnosis. It is also based on laboratory parameters. Before seeing the diagnosis, we must understand what could be the differential diagnosis of a situation. I remember in many times in ICU, retrospectively after having gone through the literature of heparin-induced thrombocytopenia, we probably have missed those patients of HIT during our ICU treatment, during the patient's ICU stay. There were many patients who developed thrombocytopenia after dialysis when heparin is being used for dialysis. There are patients who were on DVT prophylaxis, developed thrombocytopenia. We often attribute that to drug causes. We often attribute that to intravascular devices which are therein. We often attribute that to catheters which are in situ. However, the commonest differential diagnoses are antiphospholipid syndrome, disseminated intravascular coagulation like patients in ICU with MODS, patients with thrombotic thrombocytopenic purpura, that the neurological manifestations are more common and predominant with the typical changes in the peripheral smear, drug-induced thrombocytopenia, and more important is this post-transfusion purpura. Yes, post-transfusion purpura is also seen with the fall in platelet counts. This is one test which one must apply whenever we are suspecting heparin-induced thrombocytopenia. It is commonly called as 4T test, and the scoring is done according to severity of thrombocytopenia, the fall in platelet counts, timing of development of thrombocytopenia from 5 to 10 days to more than 10 days and earlier than that. Then evidence of thrombosis, new thrombosis associated with skin necrosis, cutaneous necrosis, and the other causes. The fourth T stands for the other causes. And if there are no other causes of heparin-induced thrombocytopenia, definitely that scores higher than the patients with already having causes of thrombocytopenia. Scoring is done with the low probability when the scores are between 0 to 3. 4 to 5 is an intermediate probability, and more than 6 is a high probability heparin-induced thrombocytopenia. Lab diagnosis is not that easy because of non-availability of the markers, non-availability of the assays. It's basically serologic assay which is commonly done, but it has although it has a high sensitivity, but it has a less specificity. It can be falsely positive in other situations also presenting with thrombocytopenia. Functional assays are known to be more specific and highly sensitive as far as heparin-induced thrombocytopenia is concerned, especially serotonin release assay, heparin-induced platelet aggregation assay. These are more commonly done, but then they require a higher center, a higher lab facilities. Treatment, there definitely are the paradoxes in while treating heparin-induced thrombocytopenia. Remember one thing, it is a clotting disorder and not a bleeding disorder as has been presumed commonly. Low platelets does not lead to bleeding, but it leads to clotting in situ. Platelet transfusion can increase thrombosis risk, so do not give platelets in these patients. Simply stopping heparin may not prevent thrombosis. You need to take some additional measures to treat that heparin-induced thrombocytopenia or take care of the clots which are formed. And warfarin alone is contraindicated as acute monotherapy. These are paradoxes. Now the drugs which can help us in treating this thrombosis are: one is direct thrombin inhibitors, second is factor 10A inhibitors, and third is thrombin inhibitors, oral form of thrombin inhibitors. These are the common direct thrombin inhibitors which are available, like lepiridine, argatroban, bivalirudin. They are also classified according to their monovalent action and bivalent action. We will not go into those details. Lepiridine is commonly used. Lepiridine and argatroban are approved in US, in use in United States and Canada. This is the pharmacotherapeutic properties of lepiridine. There are few limitations when we use lepiridine. It has a fatal anaphylaxis which has been reported very well, and patients should not be treated with this agent more than once. That's the biggest limitation. And because lepiridine causes formation of antibodies into the patient's body, which also recognizes the antibodies once bivalirudin is also started. So the patients who have already received lepiridine, you cannot give them bivalirudin. It is better avoided in these patients. Argatroban, it is also one of the direct thrombin inhibitors. Well, having understood the action of this direct thrombin inhibitors in post-cardiac bypass patients, the patients who are undergoing dialysis, the patients who are undergoing PTCAs or other cardiac-related procedures, the study was done to evaluate the argatroban effectiveness in heparin-induced thrombocytopenia patients in an ICU settings, in a patients who has a multi-organ dysfunction. This was a retrospective, very small study, but it has at least open a view about whether argatroban can be used in ICU. Well, it was proved that the patients with the MODS and heat can be effectively treated with argatroban, of course with some concerns. One and foremost is dosing of argatroban. The argatroban which was required in patients in ICU with multi-organ dysfunction, they were very because of multi-organ dysfunction, the doses required were very high, doses very low, doses used were very low. And excessive anticoagulation was another problem. This is another anti-factor 10A, which we are already using danaperoid, fondaparinux in our ICUs. We are using fondaparinux quite a lot. This has almost replaced low molecular weight heparin. This is a slide showing oral direct thrombin inhibitors which are available in the market. Dabigatran is available, it's a direct thrombin inhibitor. Other anti-10A direct thrombin inhibitors are also available in the market. This is study I would like to skip. Yeah, just the last slide. So the guidelines clearly recommends use of danaperoid, lepiridine, ergotroban as the grade 1C recommendation for its clinical use. Fondaparinux is grade 2C and bivalirudin is also grade 2C. Lastly, I must tell you the 6 treatment principles of heparin-induced thrombocytopenia, few do's and few don'ts. Stop heparin as soon as you suspect heparin-induced thrombocytopenia. Start alternative non-heparin anticoagulant usually in therapeutic doses. What are the don'ts? Avoid or postpone coumarin pending substantial platelet recovery. Don't start warfarin unless platelets show substantial recovery, or don't start them as a monotherapy. Avoid platelet transfusions, and you must do these 2 diagnostic tests. One is for hit antibodies, and second, you must investigate whether this patient has developed arterial or venous thrombosis. Thank you.